Dr. Alison Grimaldi, I've been very much looking forwards to getting some time with you in this expert edition. Welcome to the Physical Performance Show.
Thanks, Brad, and thanks for having me on. It's great to be here.
Well, you are prolific as per your bio in everything that you do. As a more senior physio in the industry, I've been around clinically for 17 years. You can't go far when looking at the hip without Alison Grimaldi's name coming up in some way. We could talk about any of the common hip conditions today. We've chosen to focus on one presentation that many of the listeners out there will have experienced, and certainly many of the practitioners listening in will have encountered in the treatment room, and that is lateral hip pain, gluteal tendinopathy, greater trochanteric pain syndrome. There's all these different terms, but let's explore that, shall we?
Sure.
By definition, what are we dealing with, or what are the conditions that people may experience in that lateral hip? So we're talking about pain on the outside of the hip, Alison.
Okay, so if we're talking about soft tissue related pain at the greater trochanter, then we now understand that the primary pathology there associated with trochanteric pain is gluteal tendinopathy. And tendinopathy, the term tendinopathy is the preferred term these days, and that just means persistent tendon pain and loss of function related to mechanical loading, and the tendons encompassed by the term gluteal tendinopathy, gluteus medius and minimus tendons that insert onto the greater trochanter there. But there are other soft tissues that might be involved in as, sources of nociception or pain in that trochanteric area, and that is the bursae in the area. So the trochanteric bursa that sits between the iliotibial band and the glute med and min tendons. Then there's another couple of bursae that sit underneath each of those tendons. And then the iliotibial band itself has been shown to be thickened in people with lateral hip pain. And so that can also be a source of nociception. But the primary condition is gluteal tendinopathy, and that is there most of the time. Previously, it was referred to as trochanteric bursitis, but really changes in the bursa there, in isolated changes in the bursa are extremely rare. So we're talking about maybe 2% of cases. And so it's usually there in combination with gluteal tendinopathy. So when we use the term gluteal tendinopathy in our research studies, we're talking about the gluteal tendon being the gluteal tendons being the primary issue. Plus or minus, there might be some changes in the bursa, some changes in the ITB, but we're going to treat it all the same. It's not going to change our treatment because it's all related to the same mechanism. So they are the primary soft tissue sources. And then, of course, in our differential diagnosis, there are other things that can cause pain in the area that we need to be aware of as well.
And those other conditions just can be like hip joint related, as in the joint, the lower back referring.
Yeah. So the two biggest ones are, hip joint related pain and lower back referral. And it's important also to be aware that we often get those as comorbidities. So we get patients that might have, some associated lower back pain or some, additional lower back pain. But it's important that we try to flesh that out and make sure that we know, all of the conditions that we're dealing with, because treatment might be just slightly different. Often we've got, similar parts of the protocols that might help anyone also with back pain and with joint-related pain, but there might be other specific things that we have to, do if we're dealing with gluteal tendinopathy as well. So it's important that we do try to flesh those out.
Alison, that's great. It does bring to the fore the importance of a good assessment. People struggling with any musculoskeletal ailment, the value of a good, thorough, systematic, robust assessment by a capable practitioner just cannot be overstated, because you would see it as a specialist in the field who would seek presentations. People present with years and years of the treatment merry-go-round, and quite often I imagine they've been misdiagnosed.
Yes, absolutely. And that's so important, Brad, because we do often see lateral hip pain in those with back pain as well. often what we see is patients that have been treated for their back pain, and they've gone for years and years and years with the assumption that that pain that goes, across their lateral hip and maybe down their lateral thigh is just related to their back. And so they've had back treatments, and that might have even progressed to injections or even surgical interventions. And that might help the back part of it, but may not eliminate the pain at the hip and thigh. And so it is important, I think, that we try to, right from the beginning, try to figure out, does this person have a single condition that we're addressing, or are there multiple components? And we need to make sure that we're addressing those components so that we get the best outcome from our patient, early as possible.
Yeah, absolutely. Alison, who and how? So how do the patients experience this? What are the symptoms? And then who is more likely to encounter lateral hip pain or gluteal tendinopathy?
Mm-hmm. All right. So typical presentation, one of the most important things is that the pain related to gluteal tendinopathy is over the greater trochanter. Okay, so that is important. It's not, somewhere towards the groin or somewhere in the back of the buttock. It is over the greater trochanter. Plus or minus, they might have pain down the lateral thigh. And occasionally it can even extend into the upper lateral leg. And that's probably in people who have some involvement of the iliotibial band that, of course, does cross the knee and join into that lateral leg there. So in some patients, it does cross the knee. Others sometimes say if they have pain that goes below the knee, it's definitely not related to the hip, it's the back. Not necessarily. But of course, if you're starting to get, pain in your foot and paresthesias in your foot, we're obviously not dealing with just gluteal tendinopathy there. So that's the area of pain, which is really important. And tenderness over the greater trochanter is really important as well. So the patient will often report that they have pain lying on their side at night. And to try to differentiate that between hip joint pain and tendon pain. People with gluteal tendinopathy will have tenderness directly over the bone when they lie on that side. And so they go, oh yeah, that bone's really tender when I lie on my side. As opposed to if it's a hip joint related pain, it'll be more a deeper general ache around the hip rather than that direct tenderness over the bone. And they'll also have pain lying on the other side, because even when they're lying on their unaffected side, when the knee is hanging down into adduction, they'll often get pain, on the top side as well. So pain lying on the side is a very common problem for patients with this condition. And then other key symptoms are pain standing on one leg, so standing on one leg to dress, walking upstairs. Pain with stair walking, particularly upstairs, but down as well, is a problem. Walking, and depending on the level of clinical severity, it might just be, walking 10 metres. It might be, only walking, for long walks or fast walks or hill walks, those sorts of things where we have that higher challenge to the abductors. Then we start to get some pain. For younger ones, it might be running. So it might be running or, step type classes in the gym, high step ups, things like that. So they are most typical presentations. In terms of who, the biggest population we see presenting with this condition is postmenopausal women. So about 1 in 4 women over the age of 50 will experience gluteal tendinopathy, much lower in men, so less than 1 in 10, so 8.5% or so in that age group over 50. So that's the biggest population, but we do also see it in younger active individuals. And again, I see it more commonly in females. One of the typical presentations I see in younger females is after having babies, and then they'll be getting back into their running or their sport. And it's particularly sort of those running or, as I said, step class or boot camp, things where you're sort of doing dynamic sort of control, require that dynamic control around the pelvis. So often females returning after having a baby may not have completely regain that control around their pelvis, and then perhaps increase their training volume a little bit too quickly, and then they start developing pain around the lateral hip. So they're probably the most common populations that we see.
Alison, so much great information there on the populations, just working backwards there. The young active individual, like you mentioned, you tend to see a prevalence greater in the females than the males, even in that age bracket, if you like, or that demographic. Keeping an ear out or an eye out for, new mums returning to activity levels post having babies. And then I guess that also applies in the sporting population where people are recreationally competitive. That might be the running population, and they've increased. Working with that population a bit, I see often changes in incline. So people running trails where they're running a single trail and crossing over. I guess you've had experiences like that as well.
Yeah, absolutely. Trail running has a couple of challenges, I suppose. One, you do tend to be doing more inclines, and inclines increase the challenge. Two, just where your feet land. As you just sort of indicated, you might end up on the trail with your feet a little bit more midline striking if you've got a narrow trail or uneven trail. The other thing is just that uneven surface. You will tend to increase recruitment of the muscles that help you stabilize around your pelvis, and particularly your glute med and your glute min potentially, because they're the ones that have that ability to provide that fine control. And so if you're using more motor units than you normally would, running on a stable flat surface, it just means that there's less recovery time within that muscle and within the areas of the tendons. So normally we should have this load sparing, load sharing sort of strategy where you don't use all the motor units in a muscle all at once. Of course, we just sort of share that load, and you get some muscle fibers working, and then next step we sort of share that so that we, have this little rest time in particular motor units and potentially parts of the tendon. When you're running on trails, I think that probably what we might get is that we don't get as much rest time in different areas of the muscle and tendon. And so that might, increase that relative load and reduce the relative recovery time.
Yeah, that's a fascinating concept. I've actually never heard it described like sharing of motor units. You kind of just lump it all in, it's working or it's not, or it's overloaded or it's not. So that's a fascinating insight. Alison, the other group that you mentioned, you see it very commonly in is the plus 50-year-old female postmenopausal, for example. The obvious next question is, why is that?
Well, we do think that there is a hormonal component to that situation. So when we go through menopause, of course, we establish a significant reduction in that estrogen production. And estrogen is an important hormone for turnover in our collagen, and so it can affect tissues that have collagen. So a lot of women will notice changes in their skin, but tendon, of course, has lots of collagen, and so we tend to see more of these conditions developing, not just gluteal tendinopathy, but females post-menopause will often experience more than one tendinopathy, and that might be some, lateral elbow pain, so tennis elbow, if you like, or some rotator cuff tendinopathy, plantar fasciopathy, or plantar heel pain. And so we see women in that group often experiencing more than one area of pain, and they may then end up at a rheumatologist, and because it looks like it's this systemic condition. And then the rheumatologist tests them for a systemic condition, and nothing comes up in the bloods, and then they end back at physio. So it's good for physios out there or health professionals out there, if they've got links with rheumatologists, to make sure the rheumatologists are aware that we can do something about those situations. So it just means that post-menopause, the tendons are a little less forgiving. And so we have to, look after those tendons a little bit more, getting some exercise in there and controlling, loads that might be provocative.
That's, I think, a really nice little phrase, that post-menopause, be aware the tendons may be less forgiving. And I think that's really well said. Alison, in terms of the symptoms, you were very clear on what to look for there. It's pain over that greater trochanter area. And just for the listener who may not be familiar with anatomy, where would they find that, Alison?
Yeah. So basically the greater trochanters are the bones that stick out the side of your hips. So it's the widest part of your hips. Well, in females particularly, males tend to have slightly narrower hips, narrower greater trochanters, which is probably one of the other reasons why females are more likely to get this condition. And so you've got your pelvis that you might put your hands on just below your waist, but if you go just down below the top of your pelvis, then there's some other bones that stick out the side there, and that's the anchor point for your deep gluteal muscles that come off your side of your pelvis. They join into those bones that stick out the side there, and they're called your greater trochanters.
Great. So pain in that area. You mentioned laying on that sore side in the evening would often be a sign or that we listen for or look for. But then also laying on the other side, which is something that I think is really interesting because that hip drops across and I guess adds some tensile load or some provocation to that grumpy tendon.
Yeah, that's right. So it puts you in that compressed position. Well, it's that combination of compression and tensile load. So compression occurs where the iliotibial band, that is a big thick band of fibrous tissue that comes off the top of your pelvis. It runs over that bone, down the side of your thigh and joins into the top of your leg there. And so when that band winds firmly around that bone, then we get some compression of the tissues. But also in any position where your knee is across your body, so like if you're sitting with your knees crossed, or a position where your hip is out to the side relative to your knee. So, for example, if you're standing and sag your hip or sway your hips out to the side, or if you're doing like a standing ITB stretch. So that's a position where that band is on tension. So that both causes compression of the tendons and the bursae and the band itself against the bone. And we've also got tensile loading. So tensile loading is just tension, which is just a longitudinal stretch along the tendon. So, from the muscle down to that bone. And so that position, knee in or hip out to the side, is a combination of compression and tension. And it's excesses of compression and tension that seem to be one of the main reasons, or one of the main mechanical reasons why you might start to develop tendon pain.
And then also one of the positions of provocation that would elicit pain, like you said, the sleeping positions. And sitting, Alison, what patients might expect to have some level of discomfort sitting for that reason as well. There's some compression of the structure.
Yeah, sure. So in sitting, it's a little bit variable. So some people will get pain when they're sitting and others won't get pain until they actually get up out of the chair or get out of the car. And so it might be that, when they first get up, there might be a few steps of startup pain, a little bit like hip osteoarthritis, but it'll be different because the startup pain that you get with gluteal tendinopathy will be right over that greater trochanter, and it won't be stiffness that's stopping them, coming up straight. They'll be able to come up straight, but it'll just be this, pain on loading around the side of their hip, whereas that startup pain or startup problem with hip osteoarthritis, there'll often be a bit of stiffness. They'll have stiffness, getting up to a straight position, and they may have some pain, at the front of their hip or right round that sort of, we call it a C sign, sort of from their hip around the corner to the lateral hip as well. And so that's more common in those with hip OA. But those with gluteal tendinopathy, some also get pain during sitting, and that'll be particularly bad when they're sitting in a low chair or with their knees crossed, or worse if you've got both of those things happening.
Yeah, great insights. I do recall a patient, Alison, coming into the clinic who attended a silent meditation retreat where they were in the meditation pose for, I think it was 5 days, and he had a decent case of it after that, and he was surprised that could elicit it. But when I explained the mechanics that tendons don't always like sudden changes, I think he was a bit more on board with the diagnosis.
Yeah, that's right. And that's a slightly different, position, as we said. So it's not that adduction position. It's a flexion, abduction, external rotation position. But that is one of the tests that we use for gluteal tendinopathy. And it probably just affects a slightly different area of the tendon, but more those anterior sort of aspects of the tendon that will be on some compression, and you will still get potentially a little bit of compression on the most anterior fibers in that position, the fibers that sort of will wrap around, towards the, onto the greater trochanter, but they'll be a little bit wound up in that sort of externally rotated position. Yeah. Yeah, and external rotation does wind up that iliotibial band, and hip flexion does as well. So even though you don't have adduction in that position, we've got flexion and external rotation, and the abduction position might just, affect, certain parts of the tendon.
Yeah, great information. Alison, how is the clinician out there best to assess lateral hip pain, gluteal tendinopathy, greater trochanteric pain syndrome?
Okay, so first thing is listening carefully to those clues from the patient interview. So area of pain, aggravating factors are really important. Looking at the person in front of you, do they, is there a history? Do their demographics sort of fit? So all of those things help you to develop your initial impression. Then the physical assessment. If I talk about the diagnostic tests, but just to note that, of course, we're going to be looking at people walking and look at their control standing on one leg. If they've reported that they have pain going up a step, we're going to have a look at them stepping up the step, see if that reproduces their pain as well. And when we do that assessment, we do want to really hone in on things that patients have told us are their particular problems. So meaningful issues for that patient, we need to make sure that we assess those as well. But if I just return to diagnostic tests, so when we have the patient standing, we're going to get them to do a sustained single leg stand. But for this test, we allow them to have their fingertip on the wall. They stand side onto the wall with their affected side furthest away from the wall, and so the nearest side fingertip on the wall. So they're not allowed to put their whole hand on, so they're not leaning on the wall. They just have a fingertip on the wall for balance. They take their unaffected side off the floor, and they're going to stand for up to 30 seconds on that affected leg. It's good to have a timer. So if you time, then you can, see when their pain onset first occurs, or when they get to 30 seconds. If they don't have pain over the greater trochanter, then that's a negative test. But the sustained nature of it seems to be quite useful. The more severe ones will have an onset very rapidly. The milder presentations, they may not get that onset of pain until maybe 15, 20 seconds. And so that does help. If you're only just having a quick look at someone standing on one leg for a couple of seconds, you won't get that positive. So if you perform the test like that, so standing on one leg, lift the foot off the ground behind, up to 30 seconds. And the positive is pain reproduction. So their familiar pain over their greater trochanter, plus or minus pain down the lateral thigh, but it needs to be reproduction of their trochanteric pain. It's not positive if they say, I've got some pain in my upper buttock or, in the front of my groin. It has to be that trochanteric pain. So that's, we found that to be a very useful test to help rule in the condition when it was positive. So it had a good positive likelihood ratio. Then bed tests, the battery that we would use, the PhysioTec test, which is flexion, adduction, external rotation. So we flex the hip to 90 degrees, fully adduct the hip. And so we adduct until, the pelvis first starts to move. So, you're at the end of adduction. Externally rotate to full external rotation. In that position, we've wound the iliotibial band around the greater trochanter. So we're getting that compression and that combination of compression and tension. As we mentioned before, that's a provocative position. And so that's useful for us to use in our diagnostic testing. That's part one of the test, the PhysioTec. If that's positive, and positive is pain over the greater trochanter, then I would just leave it there. But there is part 2 of that test that's a little bit more provocative, and we found that to be more useful in ruling in this diagnosis. And so you go to that same position, flexion, adduction, external rotation passively. Then we ask the patient to resist a further external rotation force. And so the patient is performing an isometric internal rotation. And with that, then we're just making it a bit more provocative because we've got the tendon compressed between the bone and the iliotibial band. Then we're asking the patient to contract the muscle. So that's increasing the tensile load. And that tends to be, quite provocative for the patient. Now, it's a good tip to always, and this is with all your diagnostic tests, test the unaffected side first, because then the patient knows what to expect. You also know, what their unaffected side feels like as well. But particularly with the Fader test, it will feel like a stretch in their buttock. And people who aren't used to doing, much stretching or physical activity, that might be interpreted as a pain for them. And so it's important that we test the unaffected side first. What do you feel there? See how you're feeling a bit of stretch in your buttock. Okay, let's test the other side. Does that feel the same or does it feel different? And I always get patients to point with one finger where they're feeling with that pain, where they're feeling that pain on a test. So we can be really particular about, is it reproduction of trochanteric pain that they're feeling? So that's the Fader test. Then we do the Faber test, which is flexion, abduction, external rotation. And so in that test, the therapist or the health professional takes the affected side and places the ankle above the opposite knee. So the patient's lying on their back. We stabilize the opposite side of the pelvis and then lower the knee down into abduction, external rotation. And so most clinicians would be quite familiar with the Faber test, but the trick with Faber is that it's a test of a lot of things. The Faber is used for a diagnostic test for, joint conditions and impingement, posterior impingement issues and the sacroiliac joint. And this is where the pointing with one finger again becomes really important. Where is the pain? So that's one thing. The other thing with Faber is just noting that range of motion. And again, that's why we want to test the unaffected side first to have a look if there's a loss of range of motion. If there's a loss of range of motion, then we might suspect that there may be a primary or an additional joint issue associated with the gluteal tendinopathy, because isolated gluteal tendinopathy itself doesn't usually restrict that Faber range unless they're really severe and have high pain levels and they're quite protective of their hip. But otherwise, gluteal tendinopathy will usually just give you some discomfort at the end of that range. But someone with a hip joint related condition, often they have some restriction in that range. Definitely if they have osteoarthritis, we'll start to see some restriction in that Faber range. So if you see range restriction, then we're starting to think we better check out the joint as well. So those are your 2 tests lying on your back. Then we have side lying. In side lying, we do, we call the test adduction just to try to separate it from a length test, but it is effectively the modified Ober's test. So we lie the patient slightly diagonally on the bed. So we're testing the top hip. And so we want to be able to lower that top leg down past the level of the bed if they have that range. So stabilizing the pelvis and then with a straight leg, lowering that leg down towards the floor. Again, it's a 2-part test. The passive test first, lowering into end range adduction. Does it reproduce pain there, trochanteric pain? And then if that's negative or if it's equivocal, so if the patient's going, not quite sure if that's pain or not, then we add the second part of the test, which is we called adduction R or adduction resisted. That doesn't mean resisted adduction. It just means adding resistance in a position of adduction. So we take them down into adduction and then we resist abduction. So the patient is trying to push up against us and we're looking for pain reproduction over the greater trochanter. And then the last part of the assessment, and I do usually do my palpation last, because I think if you palpate first, sometimes that may bias you towards, what you think you're finding on the other parts of the tests. And also if you might also bias the patient, because you've made them a little bit, tender. You've made them really focus on that tender area of the greater trochanter before you go and do all these other tests. So I like to do the palpation last. And so to do that palpation, I lie them on their side. Just legs stacked one on top of each other. I don't use a pillow between the legs for this part of the assessment because I like them to be on a little bit of tension. It's also much easier than to identify the greater trochanter because the hip's in a little bit of adduction. And so we're just, palpating then around the greater trochanter. And we do need to make sure we palpate the whole footprint of the greater trochanter. So usually we come up the anterior facet. So if you follow the vastus lateralis up until you hit the base of the greater trochanter, then keep going straight up the anterior facet until you fall off the top of it. Then we want to come over to the lateral facet and explore that large footprint. And then there's another little insertion from the gluteus medius, from the deep posterior aspects to the posterior superior aspect of the greater trochanter. So I need to make sure we go and palpate in that posterior superior aspect as well. So I think that's it.
3 facets of for palpation, which is a nice extension of just, feeling the area. It's if you can make that very specific and explore the different facets, I guess, like we might do for the hamstring tendon up at the ischial tuberosity. So easy to sort of forget that anatomy. So thank you for the reminder. And also the great summary there of a well-structured examination for this presentation. It brings up the next obvious question. Someone's been diagnosed with this accurately, plus or minus other, as you say, conditions that may be existing comorbidities of the hip or the back, so that those mixed presentations are possible. But if we speak to just the gluteal tendinopathy, what constitutes effective treatment? Now, I know this is a broad question because everyone's case is going to be different, so I understand that's challenging. But what are the keys here, Alison, to see people get on top of this?
Sure. The key facets that really should be first-line management, education and a structured exercise program. So the education involves, educating the patient about the condition so that they can understand what they're dealing with. And that's really important because it reduces that fear and it really empowers the patient because now they finally understand why they have pain. And then we can go into specifics of, why certain positions or certain tasks might be painful and what they can do about it. And this is extremely empowering for patients. And I think the education part of the intervention really helps us get some quick wins in that first few weeks. So I think dealing with the patient's primary concerns in terms of that education is also important. And that will often be getting a good night's sleep. Because if you're not getting a good night's sleep, that often, has impacts obviously on your pain levels and on your general health and on your mental state. And so if we can get a better night's sleep, that's really important. And then if they have pain with walking, what are they doing? How can we modify that? Are they walking for exercise? If they have stairs at home or they need to use stairs at work, we need to make sure that we address those things on day one, because if we can help them get, reduce their pain during those tasks, things are going to start settling down. And then we're going to be adding into that exercise program as well. So with the walking, the biggest things are, and it will, as you say, it'll be different depending on the patient presentation. But if they only get pain, for example, when they go on their walk for exercise, then you want to have a look at them, if you can, walking how they would walk when they go out for their walk. And so if you can get a bit of a corridor, and so not just looking at their walking technique, but then going, all right, so show me how you would walk when you go out on your walk. And if we're seeing overstriding. And we often see this in our runners as well with lateral hip pain, that there might be, excessively long strides. And if you have that long striding gait, you tend to get that harsh heel strike as well. That tends to really load up those gluteal tendons. We'll also be looking at their stride width, so important both for walkers and runners. So if we've got that midline striking, that's putting them into that adducted position. So we might be able to give them just some quick advice around just reducing that stride length a little bit. And sometimes easy cues are even just walk more softly or land more softly. And that tends to immediately shorten up that stride length. With runners, we might look at cadence. And so we know that increasing cadence will reduce that stride length in people that are overstriding. But obviously we have to be careful about how we do that and graduate that slowly. But there might be other things, simple things, just like let's reduce your volume a little bit, or take out the most provocative parts of that walk that might be hill climbing. So hill walks, trail walks for the moment, walking on the camber of a road, beach walking, those sorts of things are all going to be more challenging. So if we try to take out the challenging parts of the walk, we try to keep people active if we can. But of course, if they are limping in, they probably shouldn't be walking for exercise. We need to effectively load manage this tendon. If they can't just walk, 10 meters without limping, then we actually need to consider even a walking aid to help them through that. And that's just a temporary solution to just load manage that tendon more effectively. And so they can use, elbow crutch, or, even those Canadian, those Nordic walking poles can be really good. They don't have to even put too much, pressure through that pole to load manage that. So that can be really important things. Stairs, very important if they have stairs either at home or at work, or they have to, get from A to B and there's a staircase even outside that they have to negotiate. One of the biggest tips there is just where they place their feet, because people tend to be weak on both sides, and our research has shown that even if they've only got a unilateral problem, when they tend to go upstairs, they tend to shift and sway a little bit. So then they tend to put the next foot, quite midline, and then they're trying to, get that body weight up to the next step in quite an adducted position. So often stairs give you that sharp pain at the lateral hip because it's quite high load in a quite adducted position. But just asking people to walk with their feet wider as they go up the step can be really helpful. And perhaps if you've noticed, when they walk up the stairs, that they're getting lots of sort of swaying of their pelvis or their shoulders side to side, we just try to get them to, not be a rigid robot, of course, but just try to reduce, if they can, that swaying side to side. But even the simple thing of feet slightly wider, and if you can use a rail opposite the sore side, that can be useful for those ones who are really struggling with the stairs. So that sort of education. Then, as I mentioned from the first point about sleeping, sleep is just so important. And so it really is worth the time, even getting the person on the bed and going through the different positions that they can try. So, of course, they can try lying on their back. If they've got, comorbid, back discomfort, having a pillow underneath their knees can help them be more comfortable in that position. But a lot of people can't, they just can't tolerate sleeping on their back. They say they snore, or it just gets uncomfortable, or it's just not a position that they can tolerate well. If they're lying on their side and they're side sleepers, if the painful side is the top side, yes, they can put a pillow between the legs, but it needs to be a big fat pillow. A lot of patients will say to me, yeah, I've tried that, but what they've tried is one skinny cushion between the knees. It needs to be between the knees and the ankles, and it needs to be quite a thick pillow so that we're really trying to reduce that adduction. And sometimes I'll say to a patient, just get 2 pillows and shove them into one pillowcase so that they don't slide apart. because 2 pillows is annoying to try to keep there, but a fatter pillow can be useful. And then for the underneath side, if they do tend to find themselves rolling on that side, an eggshell mattress overlay can be useful. One of those waffle foams, just a normal foam, but just waffle foam can be useful. But the position we've actually found a lot of people find most helpful is halfway between side lying and prone. And so if they start in their side lying position and then they straighten out the bottom leg, then they roll halfway towards their tummy, then the bottom leg, instead of having the weight on the greater trochanter, their weight is now on the anterolateral thigh. So they've rolled off that tender bone. So they can actually then return to sleeping on their affected side. But to keep themselves comfortable in that position for a period of time, particularly if they do have coexisting back pain or hip joint pain, having a pillow wedged underneath that top hip and underneath their tummy is really useful. So they can use a body pillow or even just a normal pillow. And that normal pillow, if you sort of roll it lengthways into a bit of a body roll and just wedge it right underneath that top hip and underneath that tummy, then the body weight is taken by the pillow and they're not sort of hanging on that top hip and lumbar spine. Then they seem to be quite comfortable in that position. So the top hip as well, as long as you're keeping your knee below the 90 degrees, it is now in an abducted position rather than if you're straight on your side and you've got that knee on the bed, you are in an adducted position, adducted. But if you roll your pelvis halfway towards your tummy, that hip is now abducted. So the hip is more open, so that reduces the load. So both for the bottom side and for the top side, that position is often a good option for them.
Something that I had never explored, but I'll test it out myself tonight when I go home and see if I can implement that into practice. Thank you, Alison. And then obviously it's an exploration in and of itself, exercise therapy for this condition. But what are the tips there, Alison? Like what are the stages, if you like, or the things that people need to be aware of?
Mm-hmm. We do start with isometrics, but our isometrics are quite low-level isometrics. So they're not high load, they're low load, because what we're trying to do there is actually try to get them to, recruit gluteus minimus and medius while down training the TFL. So we just do a slow, gentle isometric into abduction. Now there's different positions you can do that in. For the LEAP trial, everyone did supine with a pillow under the knees, a belt around the lower thighs, and the knees just slightly wider than the hips so that we took away all compression. And to teach that to a patient, then you can just put your fingers underneath the belt and just say, I want you to just gently press my fingers, gently squish my fingers between your thighs and the belt. And that's the sort of action we want, like a side split action. And then we can palpate what's happening up at the hip. We want the TFL to stay pretty quiet, and we want to feel deep at the lateral hip there, and we want to feel that glute med contraction. You won't be able to really palpate glute min if you have access to real-time ultrasound. You can actually use that to see if they're getting good recruitment deep at the hip there. And so we do that little isometric. So it's a slow ramp of activation, holding for 5 to 10 seconds, depending on what their capacity is like, and maybe doing 10 in a row. And they do that morning and evening. And then during the day, also doing some standing isometrics is good. And in standing, the floor becomes the resistor instead of the belt. So we're standing with the feet just slightly wider than the hips, again, taking away any compressive load. And they're just thinking about pushing the floor apart away on each side. So it's like the side splits. They're doing isometric side splits. Again, we're trying to keep the TFL quiet there. If they can't keep the TFL quiet in the standing position, then we might lean them against the wall or lean their hands on a bench in front so they can quiet down that TFL and try to get that load really sort of focused on the glute med and glute min. that exercise for some patients can be really useful for pain relief. Not for everyone, but for some people it is useful for pain relief. And so we do the standing one at least a couple of times a day. So they might do, a few here and there, and then the lying down ones morning and evening. So that's our isometrics, but it's not like you have to do isometrics for X amount of weeks before you do anything else. We, at the same time, build a functional loading program. And so that's things, things where we have our feet in contact with the ground seems to be particularly useful for getting balance in that abductor synergy. When we have the foot off the ground, the TFL seems to, develop a little bit more dominance, if you like. But when the foot is on the ground, we get that higher level of stimulus through the glutes. And so we have a better balance in that system. So all of the strengthening or targeted work that's trying to improve load capacity for the abductors, I tend to do closed chain. So we do bridge, for example, so progressing from double leg bridge, offset bridge to single leg versions for those that are able to reach that level. Some of our patients won't, but definitely the more conditioned or the younger patients will reach that. Standing, double leg squat, offset squat, single leg squat, step up, all of those sort of functional tasks. And then depending on your patient, what do they need? Do we need to go on to some landing training, even if it's just a little step and land, I think is great for all populations. But for the younger ones, particularly if they're playing change of direction sport or things like that, we might be going on to side shuffles, agility drills, change of direction type drills, but things where we're getting that eccentric, concentric sort of turnaround and then heading towards, more dynamic landing, drop landing or bounding, things like that. So obviously, depending on what the patient's functional requirements are and recreational requirements are, we progress down those avenues. And with all of our exercises, of course, we can add extra load, and don't be afraid to add extra load even for our older populations. So with squats, we can even just adding some hand weights into the squat is really important, because our patients need to be able to carry shopping bags and walk them up a stairs or maybe up a slope. And so it's important that we build their capacity to be able to do those sorts of things. Even with bridging, putting weights on the pelvis can be good. So there are functional loading, and then we tend to also do some targeted frontal plane loading for the abductors. And that might start with something as simple as just some sidestepping. And that's great for your older population. And they might just be in the kitchen doing some sidestepping where they're focusing on the trail leg and pushing through that trail leg. And then we want to see if we can build up to some loaded weight-bearing abduction. If there is access to Pilates reformer or some sort of spring-resisted slider, that's just a great way that we can do loaded weight-bearing abduction. So we can be standing on a reformer or slider, pushing those legs apart. And so even with people who are older or more severe or less conditioned, before they're even able to stand on one leg, we can get them on two legs and pushing those legs apart. And that seems to also help with pain, that slow, heavy loading. But we start with, just moderate loading, look at that 24-hour response. And with any of our exercises, just start with that moderate level of loading and then monitor that response, not just during, but 24 hours, and then gradually increase that load. And that is an important thing as well. When we're prescribing exercise, we're trying to improve capacity and conditioning, then we do need to make sure that we are progressing them to a point that, they're working at that hard to very hard level. And in the LEAP trial, they did 3 days a week where they worked at that hard to very hard level. And we used a rating of perceived exertion. So we used the Borg scale. In clinic, I used the modified Borg, just the 0 to 10 type scale. And so we need to make sure that they are working at that hard to very hard level on the 3 days a week. And if their exercise is sort of falling below 5 out of 10 effort, then we probably need to try to make that exercise a little bit more difficult so that we can progress the capacity of that patient. For the frontal plane exercise, if they don't have access to a slider or reformer, we can do that with a band around the ankles. But we do try to keep the feet in contact with the ground to try to keep that balance between the glutes and the TFL. So one foot then is on something slidey. And so you can get slide discs or furniture sliders, even, on a lino or polished floors. We can just use, a face cloth or a microfiber cloth. So one foot on something slippery and then band around the ankles and then just pushing one foot out to the side. So we're starting in a mini squat and we're not transferring the body weight. It's a single leg abduction. So the knee starts bent, and as you slide out to the side, the knee will straighten and then bend the knee to come back in, and the other side just stays in a stationary mini squat. So we don't transfer the weight because then it's hard to get back in and you tend to sort of overload the adductors. So we just do it as a single leg skate. So that's a good home version, or a version where you don't have access to a reformer or a slider.
Alison, and obviously as I framed the question, it's such a big topic and it's so individualized, but there's some really great tips that you've shared there about making sure patients are working hard to very hard at the right time. Of course, you've shared some great offloading strategies with, sleeping, stair climbing, walking, some brilliant information there. Thank you. In summary, this is obviously a big topic, but in summary, what would you say are the biggest mistakes that you see people making with this presentation, whether that's the patient or the practitioner? Maybe practitioner mistakes separate to the patient's mistakes.
Okay. Patient's mistakes. One, I think not attending to their load management advice is really important. I think it's really important that patients take a very active approach and take responsibility for, what things can I do to reduce the grumpiness in my tendon? And I think that's really important. So if I see a patient who's not progressing, we sit down and we go through a troubleshooting list. And the first thing is, let's go through the education again. Have you changed this? Have you changed that? Have you modified these things? And often they'll be, oh, no, I forgot about that. I might have done it for the first week and then I forgot. So those are really important things, that the patient is attending to those things, because if they're not attending to things that are provocative, then even if they're doing a good exercise program, they will struggle to, get this thing completely beaten. So that's one thing that I think is important for the patient. And then I guess for patient and therapist together is how the exercises are performed is important, because a patient might come back and they've said, yes, I'm doing my exercises. We need to make sure that we are having a look and seeing how they're performing those exercises. Because, for example, if they're doing something like a step up or an offset squat and they're doing them in a way that their pelvis is shifting to the side, they're adducting through that hip, then they might just be provoking their pain. And so it's important that we make sure that the patient is performing their exercises in a way that they're going to get the best benefit out of those exercises and that they're not actually stirring themselves up. So I think that's important for therapists. Don't just hand people the exercises, or you might show them on day one, but then not check them again. Make sure you check their exercises when they come in, because even, if you haven't seen them for 2 or 3 weeks and they might have been doing it okay in that first week, but then, they might have forgotten to do their exercises for a week or so, then they've got back on them, but not really remembered how to do it properly again. So then they've been stirring themselves up. So I think that exercise fidelity is really important as well.
That's such a powerful reminder. It's easy to not explore the detail but I think the way forward's always in the detail. So that's a really great reminder. And then, Alison, just a closing remark, if possible, around the use of corticosteroids for things like the trochanteric bursa, which obviously you've seen plenty of times in your clinical life. I've seen my fair share of that, as well as the first line of strategy for this lateral hip pain.
Mm-hmm. Yes, so cortisone is still, unfortunately, from a medical perspective, probably first-line management. The LEAP trial, I think, fairly clearly shows that education and exercise should be first-line management. So if we can avoid cortisone, first up, I would rather, as I said before, if I've got someone limping, I'd rather put them on a walking aid for a short period rather than send them for that cortisone injection. Because there's a couple of things that cortisone does that might be negative for our outcomes. And one of those is that cortisone is toxic to our tendon cells, and it might influence the way our tendon then responds to subsequent loading. Second, and let me just qualify that, even if the cortisone is going into the bursa, it is still affecting the tendons. So a lot of physios will ask me, but the injection is just into the bursa. So is that a problem? Well, yes. It used to be a lot bigger problem when it used to go into the tendon, because that significantly increased the risk of tendon rupture. They shouldn't be putting a cortisone injection into a tendon anymore because of those high risks of rupture. But they put it around the tendon. And so that is generally into the bursa, but it will affect the tendon as well. And so we have those toxic effects on all of those soft tissues there. But the other thing we have is a behavioral effect. And so because cortisone does take that pain, and usually it's accompanied with local anesthetic, which is also toxic to tendon cells. And so those things together will tend to give a very rapid pain relief, reduction in pain within, straight away. And so you have patients that, because that pain's gone, they may not, even if they then have physio straight away or at the same time, they may not adequately attend to or place value on load management strategies and exercise therapy. And sometimes it's just that, pain is a good reminder. If you don't have a little bit of pain there to remind you when you're walking up those stairs, you get that pain, you go, oh, that's right, the physio told me, take my feet further apart. Oh, yeah, that's better. It's a very powerful learning tool. Pain is very powerful there. But if that's gone, they're not going to learn that lesson. And so they're not going to sort of remember, oh, yeah, okay, we should, walk in this way or change the things that I'm doing. And also, we know that patients' lives are busy. All our lives are busy. And so if your pain's under control, then are you going to go and do that exercise program, or actually, I need to do X, Y, or Z? So it's sort of about priorities. And it is interesting, like with the LEAP trial, so we had the three groups. So the education and exercise group, the group who had a cortisone injection, and a wait and see group. Now, the corticosteroid group and the wait and see group both got a basic pamphlet, information pamphlet, that told them a little bit about the condition, and it gave them some simple advice, which was around, so if you're getting pain with walking, just reduce your walking for a little while, let the tendon calm, and then gradually build up, avoiding, sharp peaks in loading. So that was all the advice they got. But both of those, the cortisone group and the wait and see group, both got that advice. The education and exercise group, of course, got that advice, but a lot more detail. But interestingly, we tracked their activity levels. Now, let me say there wasn't statistical significance between the groups, but the pattern we see is what I tend to see in clinical practice as well. So the education and exercise group and the wait and see group both reduced their activity levels for the first few weeks, for the first 4 weeks. Then they slowly increased over time and gradually increased over that 12 months. The corticosteroid group, they actually increased their activity in the first 4 weeks, and then they crashed. Their activity levels dropped right down, and then they stayed lower. Now, again, not statistically significant, but it's that sort of pattern, that behavioural pattern that we see, that if the pain's gone, then I go, right, oh, well, I can still keep walking. I can still keep doing, what I do. And so I think that then, puts us behind the eight ball with our management program. And then when the pain comes back, because it usually will come back, particularly if you start increasing your activity levels again, there seems to be a higher likelihood that the patient will seek out further injection, further passive intervention. And that's human nature, isn't it? If you've had something that has helped, you'll want to have more of that thing that is helped. But we know with multiple injections, that's going to have a more potentially adverse impact on tendon health and potentially on outcomes longer term as well.
Gosh, the behavioural effect of cortisone, I hadn't considered it in that way, in that phrase. I think that's really powerful. And for the patient that has done the exercise therapy, return to functional tasks that they'd like to be engaged with, Alison, is there some ongoing need to still stay active with that exercise therapy across their active lifespan?
Yes, absolutely. And I think that's just really important generally, isn't it? We say now exercise is medicine. Exercise is medicine. And so if you are on medicine for a condition, you wouldn't just stop taking your medicine, then it only works while you're on it, isn't it? But for people who have more degenerative conditions, they will have a potentially at-risk tendon. And so it's better if they can keep up a maintenance exercise program. And so usually a couple of times a week of some of that harder exercise is a great way to maintain those healthy tendons and maintain your physical capacity. And the sort of exercises that we're talking about, like squats and bridges and step-ups, things like that, they're great things for just, good functional strength and good functional capacity for longer term anyway. So that's great if they can keep up with something like that. But the other thing is that if we've given our patients good education, good understanding of the condition, and, they've got a clear exercise program and they know how to progress and regress their program, if they do have a flare or they have, symptoms return, they should be able to go back and go, oh, right, that's right. Let's start back on, my exercises and, get this under control again, go back to all that load management advice and settle down this grumpy tendon again.
Yeah, gosh. And what a great place to end up there, having settled this grumpy tendon. Alison, you've been very generous with not only your time, but also your incredible expertise. I remember coming to see you when I was a university student for a hip condition at the time, and being quite inspired by your practical skills and knowledge, and that hasn't ceased. Alison, where can people find you, both inside a clinical domain, as in patients wanting to see you, and then obviously your research contributions and your online content for practitioners?
Mm-hmm. Great. So I have a clinic in Tarragindi in Brisbane, which is inner south side in Brisbane. It's called PhysioTec. And I have a team of physios working there with me. So if it's not me that's available, all my team are really well trained in hip conditions. So we see a lot of patients with hip conditions. But that's where you can find me in the clinic. And online, you'll find me on my teaching website, which is dralisongrimaldi.com. And there I have a website that's more geared towards health professionals. And that's lots of different courses and resources there, free resources and paid resources, and our Hip Academy. So if you love hips or you want to get really good at hips, you might want to join Hip Academy. That gives you access to a lot of different resources and all the courses and ebooks and a big video library of all those tests and exercises that we've talked about. And we do live meetings every couple of months as well. And for patients, I'm also involved in another website called hippainhelp.com. And that website has lots of free information for the general public, including gluteal tendinopathy as well.
Yeah, absolutely prolific. Dr. Alison Grimaldi, thank you for your time.
Thanks very much, Brad.